Hello, everyone, and welcome back to the Beyond Pain podcast with myself, Joe LaVacca, and Joe Gambino. In today's episode, Joe and I dive into the foot world and we talk a little bit about plantar fasciitis. We share our thoughts about risk factors, demographics, differential diagnosis, as well as the importance of nutrition and exercise in the process and what we look for with our own individual assessments. This episode is packed with a lot of information for both clients and clinicians. We hope you enjoy this episode and all future episodes of the Beyond Pain podcast. And if you do, please remember to like, comment, share, subscribe, all those wonderful things you can do with social media to help the podcast grow. And without further ado, here is episode 9.
Welcome to the Beyond Pain podcast with your hosts, Joe Gambino and Joe LaVacca. Join the two Joes, two physical therapists, as they discuss how to navigate the uncertainties of pain so you can move beyond it and get back to the activities you love most. This podcast is for Joe, and their guests to share their clinical thoughts and ideas based on their collective clinical experiences. Can this information be for you? Maybe, but we cannot know for sure. Therefore, it is always worth talking to your healthcare provider to make the best decisions in your care before you implement anything on this podcast. And please use common sense. Joey boy and everybody else, welcome back to the Beyond Pain podcast. I am one of your lovely hosts, Joe Gambino, and I'm here with your other lovely host, Joe LaVacca, the two Joes. You can find me on Instagram at Joe Gambino DPT and Joe LaVacca at strengthandmotion_PT. We love DMs. We love having conversations with you, so please feel free to reach out to us. I'm more than happy to have a conversation, and there is an application form, so if you're interested in working with us, you can head right into the show notes and fill it out, and one of us will get back to you to chat. This is also going to be on YouTube, so you can find us at Cups of Joe _PT on YouTube. I don't have it in front of me, so hopefully I got that right. I'm 99% sure I nailed that. And we are the Beyond Pain podcast on Instagram as well, so feel free to follow along there as well. And there it is for the intro, Joe. Welcome back.
Yeah, I hope people start watching these on YouTube because, I think our flair lately, or your flair especially, I mean, we were matching pink one time. Now, you got the perfect shirt. I think that's been never created. I am Knuff. You are more than Knuff, Joe.
Thank you.
I want you to always
is
know
more
that.
than Knuff.
Yeah, I think it's getting there. For sure. The podcast is growing, and hopefully will continue to grow. But for anyone who has seen the Barbie movie, that I am Knuff line, or that the sweatshirt he's wearing at the end is still, I think, one of my all-time favorite scenes.
Yeah, it
still cracks me up to this day. So,
and
if you haven't seen the Barbie movie, go see it. It's or I guess don't go see it now. Just go buy it and watch it over and over and over again.
I was pleasantly surprised with the movie. I wasn't really sure what to expect, but they did a good job.
Yes,
I enjoyed it. Not gonna lie.
Yeah. So were you that weekend? Did you go that weekend? Because that was Barbenheimer weekend. That was when Barbie and Oppenheimer came out.
I saw this well after the fact. Not well after the fact, but a few weeks after it was out. So I was not in with all the hype, but the hype did help.
Totally.
Get me to go see it. That's for sure.
I went with my dad and my brother-in-law to see Oppenheimer that weekend. And my sister, my mom, Avery, my niece went to go see Barbie. And they came out with these glowing smiles on their face. Like they couldn't be happier. And I came out shaking. And I was like, I think we just had very different experiences. So once I saw Barbie, I kind of recentered myself, and I saw it with Court and Addison, and we all dressed in pink, and it was a really nice family experience. So
nice.
Yeah, but very different experiences.
I'm sure. I've yet to see Oppenheimer. We've been planning on watching this. It's on one of the streaming channels now, ever since I think every time the Emmys or the Oscars goes through. They just take all of them and just stick them on like Netflix or something like that. So
Yeah,
so we
exactly.
try to get through them all. But I think it's a relatively long movie, and I think that was the hurdle why we haven't seen it yet.
I think it's like 3.5 hours. Not
Yeah.
as
So
long as our podcast episodes. I think right now you can probably squeeze in all. I think this is going to be episode 9, and still have plenty of time to enjoy yourself. Be halfway through the movie. So, what are we talking about today, brother?
Today we're talking about plantar fasciitis and the foot and the ankle and all of the fun stuff that goes around that. And I know that this is, you have taught a foot and ankle class with Court, top down, bottoms up, top
Yeah,
down.
it started out as top down, bottom up. I would say I was more along for the ride, and Courtney occasionally let me speak more than we were co-teaching it. But that's okay. I mean, obviously with Courtney specializing in the foot and ankle, more people, including myself, were interested in hearing her takes on a lot of what was happening as far as even plantar fasciitis and ankle sprains and things like that. So luckily, I've been able to be in the same room with Court while she talked a lot about this stuff. So I'll share some of my own experience as well as the things that I've learned from Court here, and hopefully we can leave with some good keys and takeaways for both people who are struggling with this. And I would say struggling, having worked with many people with it, and as well as clinicians struggling, and I do say struggling, trying to treat it, having treated many people with it.
Wonderful. I'm going to let you, with you being the guru of the room, maybe not to Court's level, but by association and listening to her and seeping all of her knowledge in, right? We'll put you as the guru of this group here. So, well, let's start here, just kind of like maybe like a general overview of who is more susceptible to getting plantar fasciitis, and if you have any stats on other foot and ankle injuries, maybe something that's high up there as well, and then we can just kind of draw from there.
Yeah, absolutely. So it's very common, and it's sort of along the same line of like, just if you have a spine, you're susceptible to low back pain, and if you have feet, you're probably going to be susceptible to plantar fasciitis at one point or another. So from the data that I have, up to 4 to 7% of the population gets plantar fasciitis. Typically, though, they seem to be a little bit more middle-aged. So we're maybe in the 40 to 60 category. And here's the funny thing that I found interesting was it kind of was a mix of sedentary people and active people. And when I think about, plantar fasciitis, I always sort of assume people are doing too much. After little of a period of time, they ramped up activity, things like that. And that's sort of what overloaded the tissue. But it doesn't seem to be that way, at least from a lot of the data that I've read or been exposed to. Women do seem to get it more than men. And I think with the kind of growing literature, maybe around waist circumference and obesity being tied into a lot of things, there does seem to be this BMI factor. So with your experiences thus far, does that seem to be where your clients have been, like kind of a little bit mixed matched all over, but mostly middle-aged, some sedentary, some active?
Yeah, I would say probably on average that 35 to, maybe 40 is a start, but like 35 to 50 is kind of where I see it happen quite often. Interesting, and I mean, this is just kind of where my brain is going. And but I'm looking at like, okay, hey, oftentimes, right, it's when you increase volume of activity, right? We see overuse things happen, so plantar fasciitis pops up. But people who are sedentary, it's kind of interesting, but I wonder if it's still a similar phenomenon, right? Because like it's underloaded tissue and then you still have to go through your day-to-day. So I wonder if like, I mean, in general, right, plantar fasciitis would I would assume it, right, to be some sort of like overuse in general. So even though they're not active, there's probably some of that, a little bit of that still going on. What are your thoughts on that?
Yeah, I mean, I think we could probably, when it comes to tissue that's living and adaptive, it's like you can kind of make sense of it both ways. Like, oh, well, we can see how weight could be a factor. We can see how overuse could be a factor. But then at the same time, it's like, well, people don't usually just gain weight very quickly. It happens gradually over periods of time. So wouldn't that be enough for the tissue to sort of adapt to those loads? And then, I mean, the same thing. I mean, maybe unless you were really hitting it hard, more so than you normally would, and just going after it, which, I mean, I know we talk about that a lot. I haven't seen too many clients come in to see me and be like, yeah, you know what? I really haven't moved off my couch in 15 years. And then I decided to run a marathon on Saturday. So I know we joke about it, but I don't know if I've ever really seen someone like that. I'm sure they exist, but I just don't know if it's as common as we maybe give it credit for. Most people are on like some like very graded couch to 5K program. That's the most common thing I think I see when runners come in with pain or people come in with pain. They go online. Hey, it's a couch to 5K. I was on day 20, day 30, whatever, and then I started noticing some heel pain. But I think some other things within what Courtney would talk about or what clinicians have talked about. Is there a nomenclature difference between fasciitis and fasciosis? Mm-hmm. And we could probably make that argument or distinction all over the body, right? Because fascia is this dense white connective tissue. I sort of liken it a lot to tendon and ligament, right? In terms of like the same collagen, fibrous makeup. So is it when people are initially maybe feeling some pain for a couple of days, like that's the fasciitis, and they ignore it. They don't really change their activity. They don't, seek a healthcare provider, but because it went away, right? Why would I? And is that enough of an inflammatory cascade then with continued loading to maybe wear down the tissue itself? So it's hard to know like where to intervene here, but then once people have been suffering with it for a long time, and this is going to bring me to my next point, some of the data I've read is that it goes on from like at least 1 month to 60 months in some of these case studies and things that I've read. And it seems to be like there's a cutoff maybe around that 6 or 7 month period where if you're having pain for that long, maybe now you're trending towards a little bit more of a worse prognosis. So how do you kind of prepare people for that? Or do you see the symptoms lasting that long for your clients that you work with?
I have definitely seen this last and linger around for 7 months, a year, a little bit longer than that. And usually in the beginning, what I've at least, and this is definitely not research driven, and this is just kind of like what I've seen, is that people who are going to recover probably in those earlier months, they're going to have changes that happen very quickly on in our rehab process. So like in session 1, we're going to see like, oh, the pain comes down, the mobility improves, things seem like they're going to trend very well. And the people who take 7+ months, a year plus to kind of recover, they are like this almost like stubborn responders in a sense, where you do all the things from a mobility perspective, you do all the things that you would have done with somebody else, and it takes much longer for changes to start to settle, and even just for like a serious reduction in pain for that person. So that's probably where I kind of see, like when you see those trends like that, then the education can be changed for the person in front of you. Where if someone's responding immediately, very easy to tell them, hey, this is great. Like if you're seeing changes like this in the first few sessions, the prognosis is going to be much easier. And then if you're having somebody who's taking a few months to really start to get the ball rolling for things to start to feel better, then you can have those conversations with them and say like, hey, this is the expectations. We're not really seeing the mobility changes that happen. There's something kind of going on here that's making you a slower responder. So we need to expect that this is going to take months to happen. I think once you set those expectations, maybe there's some, they have a certain way they feel about it when they hear it, but those expectations definitely help with the outcomes, I think, because they know what to expect and they know it's going to be a little bit more up and down. It's going to take them a little longer to get there. Just kind of my feeling on it, because it's definitely, I haven't read any research specifically about that.
Yeah, well, I think that, comparing what you just said to some of the points that we've made when teaching or have read about, that what seems to put more people at risk, aside from maybe BMI or waist circumference, which might arise maybe more of these questions of metabolic sort of issues or metabolic inflammation, sort of like contributing to pain, but it is the catastrophization. So it is reporting these like constantly higher pain levels. It is probably more avoiding things that hurt. It is resting it. It is, just relying on ice or tape or like maybe more passive things. So for your point of, hey, well, if we do an intervention, it doesn't matter what, it could be isometrics, it could be manual therapy, it could be some loading strategies. And then for people to sort of see, oh, okay, well, I can shift my state here a little bit. maybe that's what helps
Mhm.
decrease catastrophization. Whereas when people maybe come and see us for this condition and probably all conditions, and Joe does something, or I'm trying to do something, or X, Y, or Z, and now I didn't have the relief I was hoping for. And then maybe that trickles down into the thought of, oh, well, this must be worse than I thought, right? And maybe that opens up that line of questioning or perception for the client to be, well, now I should go back to the doctor. Maybe I need to go to another doctor. Maybe I need to explore cortisone and things like that. So I think that that's kind of valid from what you've been gathering and your clinical experience. But then one other thing too, when we have those people who respond and don't respond, I think it kind of can put us into maybe a bucket of differential diagnosis, right?
I was just going to bring that
Um,
up.
right, yeah. So I mean, the biggest thing I think I'd want to rule out as a clinician would be any sort of like fracture to the heel, right? Or some sort of like stress fracture to the foot.
Mhm.
And that's where I think maybe your mechanism comes in. Do they have a fall? All right, were they one of those people who said, hey, on Friday, I feel like I haven't done a lot, so Saturday I'm going to go run a marathon? Maybe that's the case.
Mhm.
But typically, what I would say to people, and I wonder what you were thinking too with differential diagnosis stuff, is if there's a fat pad irritation, because I think everyone just points at the heel or points at
Mhm.
something in their body and they just label the most commonly referenced structure, like, hey, that's what hurts, so it has to be this.
Right.
But if you have a big old beautiful fat pad down there at the bottom of your heel, and that fat pad's pretty highly innervated, and if you're continuing to walk and you're loading it and that's getting worse, well, maybe that's where I'm thinking this is a fat pad issue, not a fascia issue, because for fascia and tendon, typically the more you load it, the better it is, right? And then that's where that first step into morning pain
Mhm.
comes in. You haven't been doing anything. And then I kind of get moving around a little bit and then it feels better. And then I sit and then I get up again and then it hurts again. So has that been like a pretty classic presentation for you? I mean, that's always what people talk about the most, right? The morning pain and then this like back and forth between the day.
Yeah, exactly. And that's what I was going to bring up, is that I think anytime somebody has pain on the bottom of their foot, it doesn't matter if they see a doctor or not, the diagnosis is plantar fasciitis, right? It's like, this is just what it is, right? Like any pain on the bottom of the foot is this, right? And I think you nailed it with like the fat pad irritation is one of the other more common things that I've seen where again, right, it's like those things don't really respond as well to load, right? So like there's a little bit of a differentiation there. And on your point with like the stress fractures, I've actually seen like very odd cases of stress fractures where there's like no real mechanism that would have really tied to it, but they actually came up on exon imaging. So if things are stubborn in a sense, and like they are, it was a runner, right? So there was repetitive strain that happened, but there was nothing abnormal that happened there. It just might be worthy if something is kind of lingering around, like to just rule it out. If things aren't making sense from a clinical perspective. And then that last one you have in here is nerve, and I think that's another one that kind of pops up because you can get referral pain down into the foot in different ways, and those things, and I think the most common place that we see that is like at the elbow, right? When there's so many different nerve pathways that can get irritated that can cause elbow pain, and then it's the same thing, right? It's like, oh, it's on the outside of my elbow, so that's like lateral epicondylitis, and it's on the inside, right? So it has to be medial. Um, and it's kind of the same thing in and around the foot that I found is where you can have areas where nerves get entrapped and cause referral pain, and now all of a sudden you think it's plantar fasciitis. And if you just do the things that are going to mobilize those tissues, you're just not going to see the effect. So I think being able to have someone that can help you differentiate between those structures will become important because I'm not very like heavy on like the diagnosis really makes a difference in how we're coming about like the rehab program. But little things like this, right, would make a huge difference because if you missed a fat pad versus plantar fasciitis and you didn't catch those symptoms, well, then you can be doing things that would help, that would have helped plantar fasciitis, but would make a fat pad irritation worse, right? And now you don't know what to do. So I can see those pathways there.
Yeah, and I think that's where I think for people going through this process or trying to treat this process, the notion, I think, again, across social media, physical therapy, the new age of like, no, we load and we push and we don't tell you not to, to stop anything and, rah, rah. sometimes you just got to fucking stop, right? You got to unload stuff, and you have to be able to identify when that is that stress fracture, right? Like you said, you've had some weird cases. And if you're thinking of, oh, this is a plantar fascia issue, but it is that stress fracture, it is a fat pad, well, then yeah, you're going to piss off a lot more people than you're going to end up helping. And this is where, like, yeah, rest is okay. And I think that you made that point even learning the experiences about your back, right? When we talked to you back in episode 5, and what you said stuck out to me. It's like, hey, I when I have a flare, I used to roll it and poke it and things like that. And that's what I was sharing in my episode. But you realized that that wasn't good for me. I just had to give it a day. I had to rest for 2-3 days. I had to modify my weight training experience. I had to go on more, whatever it was, walks, or, call your buddies and say, hey, I can't go golfing this weekend, but I can go mini golfing, right? Like, we can still do that together, right? And then those are sort of like some modifications. But I think that that's really important. Do you see that too? I mean, that's the message or the feeling I get from social media, is that we're kind of fallen into this gap of always push people, always load people, never rest, and gotten away from the whole idea of, I think maybe because we're just worried about inactivity and sedentary behavior, that maybe we swung this pendulum a little bit too far.
That's exactly the word I was going to use. It's industry overreaction to new information that comes out, right? Because we learn that rest isn't the best medicine, right? But that's taken out to this extreme other, the complete other side of things. And I think there's also, like, with the PT industry being an underloading process in the past, where people have lost faith in the PT system because it's like clamshells and work on the table, right? Like, now we're all overcompensating for that. And it's like, okay, well, now we just need to load, we need to load, we need to load. And I mean, I fall into that pattern, I mean, I much prefer to load, and I try not to take away activity from somebody because usually it's meaningful to that person. And I let that initial few weeks of working with someone make the decisions for me. So, I mean, I don't know how many times on this podcast we've talked about pain guidelines, but those things dictate everything. If someone asks me, can I do this? I'm like, yes, you can. Go do it and tell me how it feels, and then we make a decision from there. And you just need to respect pain. And I actually had somebody I was working with remotely, shoulder issue, not a foot issue, but I think to this point it correlates here, right? Pressing motions are the things that irritate him. We've been working on shoulder mobility, all that stuff has been getting better, but he's been noticing pain kind of creeping up a little bit. And we went on a call, we went through all the different movements, we were kind of testing things, see what's painful, what's not painful. And really what he was doing is, because he had the ability to move into the ranges, he would just blow through pain. It's like, well, the pain guideline says it's a 2, right? So I can, kind of crank through it when we're working internal rotation. I can keep going through push-ups and, like whatever, as long as they're kind of falling in this. But we're seeing pain increase, right? So I'm like, okay, let's dive into this. So our conversation was around, let's respect the pain. We can still do these movements, because when we tested it but respected the pain boundary, his pain levels actually came down and it freed up motion in like these painful ranges that we had. So now we're like, okay, well, we're not going to stop doing the things that we're doing. We're just going to respect these pain boundaries a little bit more. And I think just that little change there is going to be the difference that's going to make it where, like, pain was getting a little bit worse over our first month together to things started to get better over this next month. And we have tests. So, like, now we know, like, extension and reaching across his body are the most painful movements. If you do X, Y, or Z and those movements shorten up on you, no bueno, right? Like, go back to the exercise we know make you feel good. Let's open it up. Let's create like a positive environment and get you back on track. If you do something and it frees up more space, then those are the things we want to do more of for right now. And this way we can just bring down that pain response, so we can actually train these positions and load it and do the things that we want to do to build up that shoulder. That's how I think we need to view the activities, right? Like, we want to keep them in, but we still need to respect pain. We need to respect the boundaries of your body. And if you're not seeing the pain levels trend in the right directions, you need to make the changes. And you can't just say do it because you like it, because it's not the best thing for that person. And they're not going to be able to enjoy the things that they want. Like, he wants to be able to do push-ups at will and bench and do all those things, but he can't do it. And I'm going to do him push-ups off like pins, right? Like elevated push-ups. And he's like, yeah, the RP is like a 4. It's not that fun, but we're trying to load that pattern to some degree. So, that's what we're dealing with. So in order for me to get him back there, we have to strip it back, right? So he can get out of pain. So then we can bring these things back in for him so we can actually enjoy it. So you have to have that balance.
Right. And I know we talk about pain guidelines a lot, but I think the important message for clinicians and patients that I hope they always hear is that you don't need to rewrite your system for every new thing that comes across your pathway, right? Have your framework, have your fundamentals, and let those things guide you across the board. And I think you'll be a lot more successful when it comes to rehab if you approach it like that, right? Like have your system, go through your system, go through your thought process, write it out. And then that doesn't matter if you're really kind of then chasing a foot pain or shoulder pain or back pain, as long as you know how to classify it, rule out the serious things. And maybe that's another good takeaway from your point and what we were saying before. Hey, if you never thought about the idea of a stress fracture or fat pad, well, go on ChatGPT. How do I rule out stress fractures in the heel, right? Like we have such amazing tools now as clinicians, and ChatGPT might give you 2 or 3 tests. Cool. Take it, right? How do I rule out some fat pad issues with clients? Or maybe it's worse, just pain with worse loading. That doesn't seem like fascial tissue, right? So just having like a couple of quick checks and measures within your system, I think will help you. And I think the other thing too, within your story with your client is, something that really checks a lot of my biases with this stuff is what's the lived experiences of these people? Are we really helping them set expectations? And I like what Tyler said when we interviewed Tyler. Hey, this process is going to be painful as we work through it, and being upfront about that. Like, I do think you're going to come out better on the other side in 8 weeks or 12 weeks or 16 weeks if you're consistent and you follow the advice and we work together. But that's not going to be a linear, pain-free pathway where every day is going to build and compound. I think the other thing too is important to understand beliefs. A lot of clients, when I think they have pain or fasciitis or tendonitis, they immediately think, I'm at risk for tearing this. And I just think that that's not the case. There's nothing that I've seen so far that leads me to believe that, okay, if you developed a plantar fasciitis, you're going to be at a higher risk of tearing the next day, within the next week, or throughout the course of rehab. So maybe that's why people are kind of hesitant to load, because of the idea of worsening the issue, right? But by not loading it, you're kind of making it worse because we're not getting that cellular turnover, the healing process, and so on and so forth. So I think we need to give that better education. And then when we think about these metabolic issues or the weight circumferential issues, BMI issues with maybe a growing number of diagnoses, but even with foot pain, if we're going to tell somebody to be active or lose weight, how? And this is where maybe, working with a nutritionist is very helpful, or a dietitian is very helpful. Maybe this is where, we're looking at just giving general advice. Can you cut back on like 200 or 300 calories a day? Like, where are you snacking? Can we fill that space with a glass of water? Can we fill that space with listening to music? Can we fill that space with reading a book? Like, just distract yourself, right? And then lastly, if we are going to, sort of help them understand what's happening, I think we kind of got to go beyond the foot just a little bit, right? And then how can you stay engaged in your environment if you can't walk within your environment? How can you, load yourself in a squat, a deadlift, or a sled, or this and that if your foot hurts? So you can train upper body, right? There's no restrictions there. So can we put people on a row machine? Can we put people on a skier? Can that be their cardiovascular conditioning? Can they be on an arm bike? Right? These are easy things. And I love that, like, there's a Planet Fitness for this, right? Or there's a 24/7 fitness for this, because those memberships are so cheap, right? Like $10, $20, whatever a month. And I'm like, hey, this is a perfect time. Go in there and use that arm bike, right? Walk in there for $10 a month. You can get your cardiovascular work in, just get your heart rate going, and then just kind of feel like you're still moving forward, right? So what do you think about that? I mean, do you have a dietitian, a nurse, or a nutritionist on your team? I know a couple of coaches who do it, so I always will just kind of recommend clients reach out to those people. But how would we handle something like that, or how have you handled something like that?
Yeah, so I don't have anyone on my team specifically. My background does have a good amount of nutrition in it, so I do use some habit change stuff to help people get on the right track. But if it's something significant or really needed and it's not outside of my wheelhouse, I know fitness coaches that do highly specialized nutrition, and it's just a refer out for me. But I do want to say one thing based on what you were saying. You talked a lot about like clinicians, like understanding like differential diagnosis and, using ChatGPT. But for people who aren't clinicians, I think the one big takeaway for them is don't be scared about pain, because pain, it comes and goes. Like a little flare up here once in a while is not going to change things for you. But you need to realize that you need to test movement to figure out where you have success and where you don't have success. So this way you can live in those places where you have success for movement. So you can still train to some degree. You can interact with your environment. You can find some sort of meaning in movement. And then you realize where those barriers are. So now you can start to do the things that you can now and just work on the ability to feel better. But I just want to mention that real quick. And I want to shift gears here because we don't have kind of like already getting close to that 30-minute mark. So I want, we talk a lot on this podcast about like pain concepts, right? I mean, we are a chronic pain podcast, right? But I want to talk just a little bit about, if we're looking at the body from a movement perspective here, because we can't just like ignore movement, right? And like how mobility is and things that we can see from a movement perspective. What are things that you look for when you're assessing somebody from a movement perspective, and what are some common themes that you've seen where like these are the things that 9 times out of 10 we're working on these specific qualities?
Yeah, I think it's a great question. And I think for most people I see with this condition, it's happening when they're like walking or running, right? So I want to start to look at their gait first, or their walking first. From a sort of basic fundamental range of motion standpoint, my table tests, or my sort of like pre-dynamic tests to like before I bring them out into the clinic and watch them walk and do a couple different things, is going to be, I want to check their big toe extension. Their big toe extension is going to help them become a little bit more efficient through that gait cycle. It'll help that foot kind of rocker in and out of pronation and supination a bit more effectively. Then the next thing I want to look at is the midfoot adapting, right? So can that foot flatten, and can the foot form a decent arch? Now, there is no sort of, I think, more predisposition, again, to the things I've seen or read, where if you're flat-footed, you get more plantar fasciitis, versus if you're supinated, you get more plantar fasciitis. So I think, again, it kind of is down the middle. I would say maybe there's more of a tendency, just based on where the structures are getting loaded, for me to see more flat-footed people with plantar fasciitis. But then I think at the same time, if they're a little bit more supinated or rigid, maybe that's where they have more of an irritable like heel spur or bone spur, maybe causing some of their pain too. So I think there's a little context there, a little nuance, and maybe we can extend this out to like a part 2 or something to dive into those things a little bit more. And then as we kind of keep going up the chain, then it just becomes, all right, well, most people, I'm going to be honest, I think have 10 degrees of dorsiflexion. That's necessary for the gait cycle. So I'm not seeing too many people like stuck without dorsiflexion. So I think maybe we're, again, that's another one of those clinical overreactions where we just have to get more dorsiflexion. And I'm like, oh, I don't know. I'm not seeing too many people without with a functional limitation in dorsiflexion. And then tibial internal external rotation is important. And then I think hip extension is important. But then the hip extension piece typically would tie into toe extension. So if you're seeing probably a deficit in one, you're probably going to notice a deficit in the other. And then I'm going to start there. And then see if we can open up these spaces for joints to move, or for people to have a little bit more variability. And then maybe I'll just have them go test and walk. I think a lot of the movements that we try to observe, like running and walking, there's just too many things happening too fast. And I know that you're virtual for the most part, so it's probably even less likely for you to get an accurate readout on someone unless they're sending you videos ahead of time on a walking deficit or a running deficit, because how would we be able to do that in the comfort of someone's own home or living room, right? So I find that just breaking it down fundamentally, working on those things first, that may lead to a redistribution of forces. That may lead to us changing some behavior a little bit more. And then that's going to go kind of test and retest for me. But is there some specific things that I maybe miss that you look for, especially, again, being mostly virtual?
Yeah, I don't really think you missed anything. I mean, it's I look at the foot and ankle, make sure that it does things that it needs to do from a mobility and a function standpoint. Look at the things around it, and then maybe the only thing that you miss is like figuring out where they currently are and what they can tolerate, and then how do you start to progressively load those things, right? Because everyone has a specific starting point. So maybe they can, maybe they have pain when walking, maybe they don't have pain when walking, maybe it requires more stress, maybe it's just when they've been sitting for long periods of time, right? So what can we start to do to figure out where their starting point is and start to build up tissue quality and capacity so that this way they can, get the tissue healing that they need and kind of get out of pain and resume some of the things that they want. But otherwise, I think you did a good job. I don't think I would really look at anything specifically different than you would as far as those things go.
All right, cool. Well, then why don't we have a part 2 dive into a little bit more of what you just said? Maybe some treatment considerations, ways we would maybe bring people more through like graded exposure and assessing capacity. What do you think about that?
Yeah, I love that. And then maybe we can even talk more in general, just like how do we keep feet and ankle generally healthy, even if you don't have any issues, so that this way you can just, if you're a runner or whatever, you'd like to walk the golf course, like you want to have good, healthy feet. Like these are the things you can work on to make sure they stay good. I love it.
Sounds good. Let's do it. Part 2 coming
Well,
at you.
let's take it home then, Joey boy. I appreciate everyone for listening. The next episode will be a little continuation of this conversation. And Joe, I love you. Listeners, I love you. And if you have made it this far in the podcast and are hearing these words, extra love for you.